Are you looking for art that inspires and gives back? Check out Artery Inc., a Milwaukee-based, woman-owned company blending anatomical art with purpose. From tees to stickers, their designs celebrate the human body and support real causes. Right now, shop the End Violence in Healthcare campaign, made in partnership with PulseCheck Wisconsin. Proceeds help raise awareness and push for safer workplaces for healthcare workers. Visit arteryinc.com and wear your support with pride. That's arteryinc.com. Art, wellness, and action. Welcome to PulseCheck Wisconsin. Good morning, good evening, good afternoon. This is Dr. Ford, PulseCheck Wisconsin. Wanted to welcome you to another episode. We have a very special episode with Dr. Nkeiruka. She's a pediatric emergency medicine physician, and really looking forward to hearing some of her perspective, not only being a PZM doc, but being an international provider. So with that being said, feel free to sit back, and here we go.
Wait, no competition for how I exist in my position. Opposition tend to pop a squat and listen and present a proposition, but by the end it's probably post-apocalyptic. Now I dropped and flipped it.
All right. Well, thank you so much for being here. I gave an intro to our audience just about you, all the amazing things that you're doing. But if you could you tell us a little bit about your background?
So I am Nkeiruka. I am originally Nigerian. I did my medical school, grew up there, migrated to the U.S. this is probably 11, 12 years ago for residency training. So that's why I did my medical school. And then after medical school, usually I actually finished medical school wanting to do OBGYN for some reason. I don't know where. But at the end, I realized it was more about the kids. So the way medical school works in Nigeria is after you're done with medical school, like 6-7 years, we then go through like a 1-year program where you're rotating through like 4 different specialties: medicine, pediatrics, OBGYN, and surgery. So it was during the pediatrics rotation I realized that I really fell in love with like peds emergency. I'm like, this is like crazy enough. It's chaotic, but it's also very gratifying in terms of like, you see kids get better, you see them come like really bad, and then you're able to help them. So that's how I fell in love with peds emergency. And then how I got here is like, it's a long story being like an immigrant. So, but that's a completely different.
I tell my students all the time when they're rotating with me, there's no greater lesson as a physician than to practice in different settings, right? And like you said, even from the specialty standpoint, being able to see everything, rotate through it at the earliest stage possible in your medical education, but also, like you said, with your immigrant story, having the ability to practice in different countries and what that means for patients, what that means for communities. And as a provider, in some cases, practicing with a different standard of expectation, right? So like the MRI when I was practicing overseas in Ethiopia was not a thing that was available, right? And then I come back to Wisconsin and it's like, I've been waiting 6 hours for my MRIs. It's like, come on, man.
Appreciate a lot of things that we have here. Like, like CT scan. No, you have to schedule and come back a couple of days to get it done. If it's any. So it makes you really appreciate like stuff that you have that you never really had access to.
Absolutely. And like you said, one of the things that I came across for our listeners here, I'm going to send out all of her videos, all of the links to her website as well, just because some of the videos are just amazing for new parents that are coming up, for even teenagers. All these videos are very educational and they get into a little bit of what we see, common presentations to the emergency department, to the pediatric emergency departments too. And I want to dive into a couple of those concepts because I think it'll be really valuable for our listeners. One of the things that we talked about, and it piggybacks off of what we were just discussing there too, just how presentations are different versus here in the United States versus overseas. Here we're seeing, especially in the media, I believe you're in Texas, right?
I'm in Texas.
Okay. So we were seeing this influx of new cases, quote unquote, new cases of measles, and we see it in the media. We just saw some cases in Minnesota. I believe they just had somebody at O'Hare Airport in Chicago as well that went through there. And so everyone's ears are perked up about measles. But you've had the opportunity in your career by practicing in Nigeria to actually have seen that progression and do some of your advocacy. The video that I saw was doing advocacy to get patients to, get that vaccination to avoid those complications. Could you share with us some of your experiences just when working with that demographic, that population?
Yeah, so I think it's a really sad situation right now to be going back. Like we're going back to like the 70s and 60s when like vaccine preventable diseases were a thing. Like a lot of time between 19s and early 2000, things were getting better because then vaccines were seeing that it really works and things are getting all completely eradicated. I did medical school between the 1990s and 1999. I finished in 2006. So like 2003, 4, 5 were like peak times of like measles in Nigeria, and even like some other vaccination preventable diseases like polio, smallpox were all eradicated before then. So measles is one of those things that we had a measles ward, and I can still remember. I mean, when you go to medicine, there are some cases you will see. It's like on one part of your brain, you never really take it out. It's there. So I can still remember some patients. I still remember like a 5-year-old that I took care of who had like all the symptoms, the eyes, the breathing, and I still remember the location he was on the pod. I'm talking about in 2002. I still remember that. So I'm not saying this to scare people, but it's just to say that we know that this illnesses existed. Medicine, there are some places, especially in developed countries, you read some things in the book and you just have to remember the symptoms to be able to pass the examination. I didn't read that in the book. I saw this like rotate. I take care of the kids. Of course, we had protective wear as much as we had. We didn't have all those like N95. So you're even going in there to care for the patient, not knowing if you're going to get infected. I was fully vaccinated. But it's like you have the protective wear, enough of the ones you could, but you still have to care for these kids. So they're on, what do they call it? Breathing support as much as we had available then. Of course, not all of them made it. One of the most common symptoms we also had was diarrhea. And of course, Nigeria is a developing country, which is like diarrhea. And then in a combination of malnutrition, a lot of kids had more severe symptoms. We have developed countries and developing countries. We had more severe symptoms. So they're coming in like dehydrated. We're losing some of the kids because they're having a lot of diarrhea in combination of other symptoms. So these are the things that you could prevent. And our vaccination status then was not because people were refusing vaccines. It was because we didn't have enough vaccines then. And also the storage made some of them not reliable. So even if these kids were vaccinated, they were not fully vaccinated. So like we had the vaccines or we didn't have enough, but people wanted it. Now we're talking about now where we have the vaccines, we know that it works and people are refusing it because I think we're now in a society where people think that they can do Google research or they hear from other like wellness people and they think, oh, vaccine causing this. I'm not trying to discredit people's experiences and hesitancy, but I think seek your sources from the right place and if you want to read stuff that people actually send to you, there are people that are professional that have been doing this research for a long time. It's about what sources you're looking for. But please, Google is not the right place to find information for vaccines and say no, because I see things in the air I've been seeing for a long time that are actually taking us back to where I really don't want us to get to.
And bravo, right? And that's the thing, don't seek Google, don't seek Instagram or TikTok, especially those avenues. In recent years, it's been this wellness, I won't necessarily say attack, but it's more so this wellness movement against the common, Western medical societies where evidence-based medicine is our approach. And it's always been that approach, in modern years where we're looking to say, okay, this is what the trials say. This is what the patient data says, and this is what we're seeing in our population. And to be frank, we've had this almost nearly eradicated, right? Like you said, in like the, early 2000 to, 20 teens, we had this eradicated. And I believe the very first time you brought up a good point in that, we read the books, we saw these case studies, we had it on tests in terms of, the symptoms and, the spots and everything else. And my first interaction with somebody with measles was in Minnesota when I was in pediatric emergency medicine fellowship. And that was the first time I had ever seen it. And that was the first time that the attending I was working with who was a 20-year veteran had seen it. Right. And so, it's one of those situations now that we're seeing it come back now. And I feel, to your point also, that a lot of people who are in that, that wellness community, in that anti-vax community, they seem like it seems to be this air that it's not that big of a deal. What are your thoughts on that? You've seen it.
I think in terms of, there's a lot of confusion now, right?
Mhm.
Before, I don't think we had a huge social media platform and things available compared to what we have now. And I think a lot of people, maybe there's been so many experiences they've had with healthcare, with vaccines, that actually makes them sit on the fence.
Yeah.
So it's now about who is going to tip them over one side or the other.
Mm-hmm.
Unfortunately, the wellness and the anti-vaxxers tend to be a little bit louder than the health professionals. And then somehow some health professional also like tired of fighting misinformation
Yeah.
and tired of being bullied or threatened. I mean, I know after that news, I know what my DMs look
Yeah, I'm telling you.
like. So I know there's some people who are not able to continue to be able to spread the right information after this whole situation. I wish we're able to. So I think that's the situation. So I'm not saying that there are no families that have not had, that there are no families that have had or that had any like experiences that make them a little bit hesitant. It's about, I know you're hesitant, but I still need you to understand that going the opposite direction is going to make you worse. Like I work in the ED, I've had some families who, like vitamin K is another one that I'm having families like refuse. I've seen some kids come into the ER with bleeding because they didn't get vitamin K. But how many people come back and share that experience on the internet? They don't. They share the ones that happened because they got it, which may not be really true. So that's what we need to be hearing. People that are having experiences for not receiving vaccines or receiving the right care or receiving the right things that are recommended should actually also come and speak up and say, hey, this is what happened. I wanted to know that this is actually not right.
Yeah. I've seen some of your videos, especially on YouTube, where you're addressing, and I like your approach to it as well. When you see it from both sides, and we're not saying that there hasn't been, there's been zero accidents associated with vaccines, and we're not saying that those patients' experiences are not valid. But how do you approach it? How do you approach patients who are hesitant in the emergency department? And I'll go one further to say, I've seen patients that have come in, kids have been unvaccinated, and unfortunately we had to do the full septic workup, including the lumbar puncture and everything else, just because we're in a situation where we don't know what that is, and the child is at increased risk, and parents are floored to learn that we have to do all these invasive things. But how do you approach that in your practice?
This question is always, what is your hesitance? I want to understand from your point of view, what's your concern? What's the hesitancy? Where did you get the information from? Is this just like experience, or this is what, like I always want to hear that first. Because if they're telling me, oh, this happened to my child, or this is what my regular doctor said based on this, I usually give them some time. I say, this is what I know. I may not be able to convince you today, but this is what I know. This is the information. You're probably not going home today. So I want you to think about that. I'll let the inpatient team kind of help you, give you more information and help you make a decision. But as a family coming to tell me, like, it depends on the tone too, telling me, oh, this is what I saw on the internet. I'm like, no, this is like straight up, like, it's completely wrong. This is what it is. This is what the evidence is. And I'm doing all this for a child now because you declined the vaccine based on no reason, or based on maybe an uncle or aunt that said this is what it is. No, this is incorrect. And this is the right thing. And this is what it is. It's up to, I mean, everybody still decides what they want done for their kids. But in terms of, I mean, unless you want to sign against medical advice, which is something we don't recommend in kids.
Yeah.
But I can't hold you down, but this is letting you know that this is completely incorrect.
Yeah, and it's getting harder, right? And I don't want to get overtly political or anything like that, but when you have, the HHS director saying one thing that, again, stands in direct opposition to some of the literature that we have for years at a time now, it makes it harder for the patients, and looking at it from their perspective, to say what is real and what is fake. What should I be putting my stock in, especially when I'm trying to look out for my family. But I will say personally, one of the things that gives me pause is sort of the approach that we're seeing now taken to certain ailments and certain environmental diseases that affect, the populations that are historically most affected by these conditions, right? We have here in Milwaukee a lead issue where we have lead in the soil. We have lead that recently was discovered here in our schools, and the federal government is not allocating the funds that were once, previously allocated to those efforts. And so I see that. And as someone who is trying to be as objective as possible in that situation, my concern is if we have something that is endemic in those communities, those same communities, like measles, right? That response is going to be the same. Like they're not just going to jump up and say, okay, this community is being disproportionately affected. Let's give them resources. So, I think a lot of folks need to consider that too. That next step. If your child gets infected, now what, right? And so that's the other way to look at it.
Yeah, definitely. You know what I mean? Sometimes you can provide people with resources and just kind of wait for nature to do its thing.
Right.
I can't
Yeah.
can't do anything. I've had families who maybe decline something before they're leaving, like, oh, probably just give us a vitamin K because I don't want this to progress. Like,
Absolutely.
great. Because now they learn from experience, which most of the time you don't want them to. But I mean, I don't have anything else to say versus this is what the research says, this is what is true, but that's all I have to offer at this point.
Another thing I wanted to get in was some preventative steps. So a lot of the work that you do on your social media platforms is more so prevention to try to keep folks out of the emergency department, how to keep kids safe. What are some of the most common injuries and or presentations that you see to the pediatric emergency department in your practice?
Yeah, so that's a pretty interesting question in terms it depends on the day and the season. Like the ER is one of those places you always say, you never know what you're going to expect till you get in. Like you may just go in and, oh, it's sunny. And then you've seen a bunch of injuries happening inside the house. So it depends on the season. So let's say now we're in the spring, a lot of kids, or spring versus summer, depending on where you are, a lot of people are going outside. It's like lawn mowing season. It's a garage. A lot of people doing work around their garage and around the house. And then also kids are starting to go to the playground. So now I'm starting to see some lawnmower injuries, which may be to the eye, or even like kids run over, or maybe things with the garage, kids getting amputation, which is like your finger cut off because they accidentally go through like a sharp machine in the garages. And then things like head injuries from a fall, monkey bar, it's a huge one, trampoline injuries, and then sports injuries as well. So those are some of the things that we tend to see based on the season. And then times where kids are more inside, like cold fall and winter, it's more like injuries from like playing inside the house, which you can't probably keep kids like, you can't put them in a bubble. So like falls from jumping off, like doors slamming on the fingers from like siblings running around in the house and stuff like burns as well. Those are some things we see like in the winter season.
Yeah. And, this will probably be one of the more controversial things that I'll say on here, and it's going to get people up in arms. But I used to work for a plastic surgeon before I went to medical school, and he was a hand specialist. And he would see lawnmower injuries in kids so frequently that he would often come out and say, no child should be touching a lawnmower, period. It was like, if you are under the age of 12, you shouldn't even be outside with a lawnmower. And it's just because it's so unpredictable, and we see it so frequently that, some of those wounds are devastating. And in opposition to some of the things that you may see on TV, a lot of times those limbs can't be reattached. I know people come in with the ice bags and everything else, but that's the reality that we deal with. So please stay away from the lawnmowers.
Yeah. I usually tell people, like, once the lawnmower is out, every child should be inside. Because people are like, oh, my kid, I want to multitask. They can run around. Like, you always have a lot of, like, loose things flying around, and kids cannot be one place. They can sit inside and then you can move along because anything can happen in a split second, like you mentioned as well.
Absolutely. One of the videos that I really liked that you did was on head injuries. So we see head injuries in kids all the time. My kid just fell like at 9:00 this morning. So it is inevitable. But one of the things that you talked about was how you approach the old adage of, you got to keep these kids up, as long as you can, keep them up overnight. Don't let them sleep. And I feel like as a provider myself, this is something that I run into, and I make sure that I have to say at the end of every visit, just because the evidence has switched away from that. Could you talk a little bit about that and to that point?
Yeah. So, I mean, that real, like, we're still like having conversations around it. But head injury, like you mentioned, it's one, when you mention kids, equals head injury. Either from when you're young and curious, or maybe in sports and like active and teenagers, like always trying to do stunts. So head injuries always happen. So I want families to, as much as you feel bad when your child bumps their head, just know it's something very common. I always like to say, especially for younger ones, think about it this way. Like, if no one told you that your child fell, would you be worried about them? Let's say you walk out now, you see your child actively running around, acting like themselves, and no one told you they fell. Is there anything you're worried about? If there's nothing that has changed, then the kid probably has moved on and they're recovering on their own. They're eating, playing, like nothing happened. But if now you come and wonder, why is my child stumbling? Why are they not talking like normal? Why is something different? And someone tells you, oh, they actually fell. Then I would want you to observe to make sure that something is not completely off. Because if they fell down now, all of a sudden they're very sedated in terms of like sleeping so much that you can't wake them up. They're vomiting a lot, or they're stumbling and being unsteady. They need an evaluation. When it comes to the part about head injuries, what we're always concerned about and want an intervention is the brain bleed. Even fractures in kids, which is a broken bone, a skull fracture, typically heals on its own. And even neurosurgeons are like, oh, there's nothing I need to do about the fracture because their bones are pretty, they're pretty resilient and it heals very well. So when families hear about head injuries, they think about fractures and think about concussion and forget what we're worried about is the head bleed. Bleeding in the brain, the reason we're worried is that when there starts to be a bleed in a container, it's squashing the rest of the things on the side, which is the brain. And anyone with the brain bleed is what we call significant brain bleed is going to develop symptoms. And those are the symptoms we call red flags. So in the past, we used to say if a child bumps their head, keep them awake so you can see those symptoms. But then over time, we realized that when a child bumps their head, you keep them awake. Like if I bump my head and I'm all doozy and I'm tired and you keep me awake, one, my brain is not recovering and my head is not resting from what happened. So I will also be exhausted. So by the end of the 4 to 6 hours, people can't really tell, are you exhausted from not resting or are you exhausted from the red flags getting worse?
Do you need a CT?
That becomes, yeah, exactly. Can you imagine? So a lot of people were ending up like in the ER and so many places getting evaluation because, you can't figure out why they're exhausted. So the reason we recommend letting them sleep is now they can sleep and rest, even if it's a concussion, which I have another reel coming up. Even if it's a concussion, it helps with brain recovery. And that recovery is what helps them get better. Red flags from head injury and bleeding manifests regardless of if your child is sleeping, meaning that they will be too sleepy. You can't even wake them up because you want to go observe them, say, call them and make sure they can recognize you like intermittently. But a child who has a significant head bleed and it's having like red flags will be vomiting through the sleep, will not be able to wake up, will look completely altered when you attempt to wake them. I have like multiple, which I can send to you to put in the caption. So you can let them rest and sleep and just check on them and check the red flags. But please don't keep them awake because then you can't really tell what is going on after. So that's why recommendations change. And that's what we're recommending, right? It's very difficult to convince families.
It is.
It's very for that, but that's what we have to check on.
Yeah. And to parents, again, you're off the hook. Go ahead and let the kids sleep. I know it's really, and a lot of what we do, especially in pediatric emergency medicine too, right? Like a lot of it is this is the way that families have approached these issues for years at a time. And, our evidence in medicine, especially in pediatric, changes so frequently just based on, that scientific approach that we do, the evidence that we're able to review. And then as we get more patient cases, we're able to review it again and just to make sure that those guidelines are up to date. But I will assure anyone listening, the pediatric guidelines for head injuries are one of the more rigorous studies that we have in medicine, period. Like, it is an outlier in that respect. And so if your child is not experiencing some of those red flag signs, as you said, it's something that you can continue to watch your child, let them eat, let them go to sleep. If they have a concussion, not letting them sleep is going to make it even worse, right? So,
Exactly.
just go ahead and let them be.
Yeah, because I think some people always assume that if you let a child sleep, your concussion gets worse. No, there is a concussion regardless. It has already happened. And then like people always think, oh, I want a CT head or an MRI to be able to make sure or tell me if it's a concussion. No, I can tell you it's a concussion based on your symptoms. A CT would tell me there's a bleed or if there's a broken bone or like a skull fracture, but a CT is not helping us with a concussion because they probably already have it.
Yeah, and that's a good point too. A lot of people come in and they want that CT scan because they want to make sure that the child does not have that head bleed that we're talking about. But as you spoke to, a lot of those times where there is a life-threatening bleed, like we will see it on a clinical examination, and like you mentioned as well, concussion cannot be picked up at all on CT scan. The only way that you can potentially extrapolate some data based on that is on fMRI, which is our functional MRIs. And that's usually used in tests, in studies, right? Like that's not really used. It's not ready for prime time as of yet. So, on the other end of that coin too, on the other side of that coin, it is more so harmful for kids to continue to get those CT scans. Your lifetime of radiation exposure, we try to reduce it as much as possible in pediatric patients, just because you're going to continue to carry that burden of that radiation exposure, which can precipitate cancers and things like that. So often we'll tell my patients, and I'm sure you do too, we are mitigating this, how much of a risk is associated with the head bleed versus how much of a risk am I going to expose this child to radiation and then increase their risk of cancer in the future? So it's a gentle balance that we work in.
Yeah, definitely. Yeah, so true.
So one of the things too that you mentioned as well, it was more so the presentations to patients. We see commonly fevers in the emergency department. Kids, especially little kids, have a very interesting, well, more so I would say distressing presentation to the hospital sometimes when they have a fever. Sometimes they may actually have seizures. And I just saw a patient, it must have been last week, at a rural location I was working at, and the kid came in season. And, the whole hospital stopped just because it's a primarily adult hospital. And,
Adults, once we get adults, I'm like, no, you need to go.
You need to go, bro. And it's right. And so, if you don't see it often, there were people rappelling from the ceilings. It was insane. I don't know, with backpacks and everything. Everybody just back up. We just need some Tylenol. So we call those febrile seizures. Could you talk a little bit about what that is and, just how distressing that could be for parents too?
So, febrile seizures are one of those things that, regardless of how many times a child has had it, it's always going to be scary for families. Growing up, one of my siblings actually had febrile seizures when I was 7. And I still remember, like, all those things you remember, like her shaking, having the seizures, my mom yelling. It's very distressing. So febrile seizures, essentially seizures that happen when kids have a fever, but it's within the ages of 6 months to 5 years. If your child is outside of this age range, we actually consider a more extensive evaluation and not call it febrile seizure. So if a child is younger than 6 months old and has a seizure with a fever, we're more concerned about like another brain infection versus just a febrile seizure. And if your child is older than 5, sometimes we say older than 6 years old, we don't consider it completely a febrile seizure. So we do a little more extensive evaluation. So the reason that we understand kids have febrile seizures is because at that age, the way their brain responds to a fever is a little bit different, triggers more electrical activity, and that's the way their body responds. And depending on how long it lasts, what type of seizure, it can be characterized into like simple and complex febrile seizure. So about how long you're seizing for. And most of the time, the simple ones, although people always confuse this, is when your whole body's shaking versus where one side is shaking. I have like an extensive video on my YouTube on that too.
Yeah.
But a febrile seizure. So, and most of the time, a lot of kids that have one febrile seizure might have another one. I think about 30 to 50% within that age range of 60, when they're 6 months to 5 years. After 5 years, they probably might resolve completely or not have any other seizures at all again. And depending on if it's a simple versus a complex febrile seizure, there's a probability that you may have no brain impact at all. Kids that have prolonged or complex febrile seizure may have a chance of having seizures or epilepsy growing up, or may have a chance of having brain development impacted depending on how long the seizure lasted. But simple febrile seizure, it's like we call it the best type of seizure to have, because it completely resolves and you have no other likelihood the kid grows up like normal, nothing again going on. So it's very concerning. It's like stressful to see your child having a seizure, but it's the best seizure to have. And understanding what it is kind of makes it a little bit easier. What we look for is, what is the cause of the fever? So we're most depending on the season, we're looking for what virus is it a strep throat? Do they have an ear infection, pneumonia, or a urine infection as well? So that's what we're looking for. And when it's none of those, the discussion of telling the family, hey, it's none of these, it's a febrile seizure. That's where the discussion gets hard.
Oh, yeah.
Because everyone wants a diagnosis.
I need it now.
Everyone wants a diagnosis. That's what I take time and say, hey, it's probably a virus that's not completely declared itself. These are the things that it's not. This is what to expect. This is what to do going forward. I'm just going to give them time to take it all in and ask all the questions they want, because it's one thing I never say it's fine. It's not fine. Like febrile seizures are just, regardless of being like benign, it is not fine. It is stressful as it.
Absolutely. And that's the thing, you're a mom, I'm a dad. If either one of our kids had a seizure, the doctor title goes out the window, right? And it's one of the things for anyone, for any parent, it's distressing to see your child like that. Kids sometimes become apneic, they turn blue, right? And we always, I know when patients come into the emergency department, one of the questions that we always ask, because it's in the criteria for, is this a simple or complex febrile seizure? How long has it been? Common answer is, it seems like it was forever, right? Yeah. Because, it could be 10 seconds and it could seem like, you're in a vacuum watching your child in that level of distress. And so, we feel for you coming into the emergency department. We have very strict criteria based on like what to be concerned about. We're doing this work up in the background too. And as I always tell my patients too, you get one, right? You get one of these seizures before we have to start stepping up and saying, okay, maybe this isn't a simple febrile seizure if it happens within 24 hours. So just know that we hear you, and we're there with you, and it's not okay. It's not
okay.
Yeah.
And I think one of the things I always tell families, which is actually pretty difficult, is recording the seizure. Because then it gives you an idea of like what type of movement it is and how long did it last. Because you never remember like what type of seizure, like, I don't know, I just know my child was not right, which is understandable. So I tell families, if you can, seizures are one thing we always recommend to record, because it makes it easier to see what the pattern is, see if this is an abnormal type that we need to like escalate and do more evaluation.
And that's a good point too. And, that'll be good for my group as well, because that's something that we can start wrapping into some of our patient follow-up as well. Because some kids will, as you said, develop epilepsy, develop some form of partial seizure or generalized seizure in the future. And it's good to know that. And in a lot of cases too, if they have that history, they may receive a prescription for some anti-epileptic medications for home. And so all those things are really good for families to go forward in knowing. One of the things that we often will differentiate, as you spoke to, was, is this related to, a virus? Is this related to a bacterial infection? Are they febrile? Because seizures can be caused by a lot of different things. And one of the things that I recently saw was an ingestion of medication. So we see toxicities, in pediatric patients that are coming in. My kid came in, the child I took care of came in from grandma's house. Grandma had her medications on the kitchen table and got into it. And so I'm sure that's something that you see as well. What are some of the common poisonings that you see in kids that are presenting to your emergency department?
Talks about it like grandma on the table. I feel like the fastest humans alive are toddlers.
Toddlers.
The crawling child and a toddler. That's like the fastest like people alive. And I think now for us, we went through like a whole peak for THC. Especially the gummies. Those are the ones, especially would be legalized in different places with teens and young adults. These are the ones we're seeing a lot. And as much as people always say, oh, it's not going to kill a child, it makes them so altered and drowsy. The blood pressure is so low. It has a lot of cardiac, like heart effects on kids. And that's one of the most common ones we see. Like throughout like end of last year and this year, like any kid who looks like altered, not doing what they're supposed to do before, not acting right, we always think about THC. That's like the gummies and all the ones. Those are the ones that we've seen like a lot lately. And then like coming down to like, depending on whatever medication like is in the house, as easy as like Tylenol, acetaminophen, ibuprofen, medications, pregnancy-related medications, folic acid, anything like colorful, exciting, not even colorful, anything like pill form is what like kids are like grabbing and putting in their mouth. That's what we tell families. Like always think on the level of a child, like come down to the level. Anything their hands can reach, anything exciting that seems like exciting to you it's probably pretty exciting to them. Just like take it out high up where they cannot see or reach. Because once they can see, especially when they can see you taking it, they're looking at you, see where does it end up? And they will climb to get it. So any medication, anything at all that you think isn't safe, you think is safe for you, but looks like it's not going to be safe for the kids, just not make it available or within eyesight for them.
And, to your point, some of these medications that are not that harmful for adults, you have to think about the dosing as we do as pediatricians, right? Do you think of it in the milligram per kilogram dosing, right? So you're an adult, average adult, 75 to 100 kilograms plus, right? And so that dose for a pediatric patient can be toxic and can be, for Tylenol, for instance, right? Tylenol is one of the most dangerous medications. In other countries, it's available in blister packs. We had this conversation with my pharmacist the other day. You have a blister pack of 25 tablets, right? You come here, you can get a Costco bottle of 300 for like $5, right? Right. And so, but Tylenol is one of the worst toxicities that we see commonly in the emergency department because it affects your liver. We see people go into liver failure. You have to act very quickly to reverse it too. And for a kid who just, all of a sudden pops it in their mouth, that can be a toxic level of ingestion if they just, get a couple pills in their hand. And so it's something that, to your point, you want to make sure you have that. To your other point about THC, I almost intubated a kid the other day who ingested a THC gummy, right, that they got over the border from Chicago, right? So totally legal in Chicago, but looked like a gummy bear. And so the kid popped it in her mouth. And fortunately, we were able to resuscitate her enough and admit her to the hospital. But these are things that, like I said, if it's good for mom and dad, it may be deadly for that toddler.
Yeah.
No.
And also, I usually tell families too, especially during like holiday season when you have like visitors coming around, like aunties and uncles staying. I had another kid who I think the uncle was visiting, and uncle had like a stash of like THC, which family probably didn't know.
As uncles do.
Who's probably kept saying there's no medication in the house, there's nothing in the house, and then they realized, oh, by the way, uncle was visiting. I'm like, okay, so that's it. That's where it's coming from, because the urine was positive for THC, and no one knew where it was coming from. So I would say you can be. You can never be an overprotective parent. Just tell like your visitors, oh, hey, just in case you have anything, you're being safe. We have younger kids. Please do us a favor and keep things like secure, because we don't want to have conversations or we have visits that are not necessary because we didn't have those conversations.
Absolutely. What is one thing that you wish every parent or every caregiver knew that would keep their child out of the emergency room?
I think car seats and seat belts.
Okay.
If there's nothing else we do, I mean, especially for someone who didn't really grow up like using car seats and now taking care of kids who would have been saved or who would have had less injuries if they had the right car seats or the right seat belts, car seats and seat belts. There've been enough studies done, and there's been enough lives saved. Like I can tell you've had families who, in the same car, being brought in, but I can tell you who was in the car seat or who wasn't. Based on who gets. Like the impact is so huge that I tell families, you don't even need. I mean, some families tell me, "Oh, we're just going down the street like 5 minutes to buy ice cream," and they got impacted, and the kid, and in particular, I remember this kid who died, and that was the story. It was just like ice cream 5 minutes down the road, and it wasn't far. So I was like, car seats, it doesn't matter where you're going, as long as the car starts before you guys are leaving, car seats, seat belts have to be on, and no child younger than 13 should be in the front seats. Please. I always beg families, please. It's one of those things, that can be very, very avoided. And then my second one is helmets. I always tell families, we can pretty much like repair like broken bones, lacerations, a couple of things, but we cannot really repair a broken brain. Like you cannot undo that. Helmets in like your scooter, your bicycles. I mean, ATVs, I hate ATVs.
Oh God, don't get me started.
I always tell my kids, listen, if peer pressure ever sets in because you're with your friends and they have an ATV, you're really excited to try it, please wear a helmet. Because then I know if anything happens to you, you have a hip fracture, a laceration, your brain is probably going to be intact. So anything that has wheels, helmets, they save lives and save brains and save families, because then any family that's been impacted with an injury, with the helmet not worn, and the kid ends up like that, there's a lot of like emotions and things that go on in families after that. So those are the two main things that I wish all families know.
And those are right on, right? And one of the things that I think is kind of anchored to that is the approach that I've heard in the emergency department over and over again when I've given this sort of, precautions to parents and going forward, and to even patients. A lot of times it's not even the parents. It's kind of like grandma, grandpa, sitting in the back and say, well, we used to not have to have car seats, and we used to play in the back seat all the time. I remember climbing up on the dashboard and the console and all that. And I remember but times have changed, right? Like we have a better way to track these injuries, right? So to all those people who are saying, these never happen, it just wasn't recorded. It happened all the time. Like there is no way, Like we are seeing this frequency of injury, and patients just either stayed home or they lived in rural locations where it wasn't recorded. So it happened back then. So we're trying to do all that we can to prevent these injuries, because these injuries don't need to happen. And these are lifelong disabilities for some of these kids, and life-threatening injuries that we can avoid just by wearing the helmet, just by making sure that they're in an appropriate, non-modified car seat for their age and for their weight, sitting in the right orientation. So you mentioned earlier on, patients should be able to, access those evidence-based pieces of information, not Google, not go to, Instagram, Facebook, or wherever. Where, in your estimation, can families find, accurate and trustworthy information and resources about pediatric safety and pediatric conditions?
See, there's a couple. AAP, which is American Academy of Pediatrics, has like a publications, especially for those who like a lot of like research and things, have like a website where you can get like a lot of that. But then healthychildren.org now takes that information and breaks it down into easier to understand things for both like providers and for parents. So either you're going to AAP website and publications, or you're going to healthychildren.org. And then Kids Health, I'm trying to think if it's .org or .net, is actually another great one. They have like pictures, easy to understand things for like families as well. So those are the three, I'm sure there are probably, but those are the three main resources. Then of course, like a shameless plug by YouTube, I would actually take all those information and then kind of break it down, use like experiences and information as well, just like to communicate you through different ways. But those are the three main ones that are very helpful.
Yeah. And to close it out, how can people get in contact with you, follow you, and how can they find that YouTube channel that you post all those amazing videos on?
Yeah, so my name is the Peds ER Doc, THE, Peds, PEDS, and ER Doc, both on YouTube or on TikTok, and then also on Instagram. My Instagram handle is a little bit different, Dr_N or Rajaka, but then it's the Peds ER Doc on almost all the platform, and then Nkeiruka.com, which I'm going to let you know how to spell all of those.
Awesome. Well, thank you so much. I appreciate you coming by and talking to us. Looking forward to working with you in the future, talking more. Feel free to reach out to us. If there's anything that we can do to help support your work, please continue to give us that amazing information that you're doing. It's very helpful.
Of course. Thanks for having me.
All right. Thank you, my friend. All right.
Okay.
I want to thank you so much for joining us here today. Thank you to Dr. Nkeiruka for dropping some much needed pearls about pediatric emergency medicine, as well as some of her insight from being a global provider on vaccines, as well as the importance of evidence-based medicine. In recent years, there has been an attack on evidence-based medicine, as well as the scientific approach that we apply as providers. And like Dr. Nkeiruka said, this is something that we need to continue to fight as physicians, as allied healthcare providers, in order to promote the scientific method, as well as in order to promote wellness amongst our communities. We have to have a standardized, regimented way that we go about this in order to promote the public health and to prevent preventable diseases in this instance. Looking forward to seeing you on our next episode, which should be upcoming soon. And with that being said, as always, take care of yourselves, take care of each other, and if you need me, come and see me.